Good morning, good afternoon, good evening, and a very warm welcome to this PMAC panel, a plenary session on health systems in 2030. What will they look like? My name is Gavin Yamey. I'm a professor of global health and public policy at Duke University, where I direct the Center for Policy Impacting Global Health, and I am coming to you live and direct from the lovely city of Durham, North Carolina, USA, where it is 6 a.m. and I am very honored to be your moderator for this exciting event. I cannot think of a more urgent, a more compelling, a more timely topic in all of global health right now than health systems. So allow me, if you will, to just very briefly set the scene for today's plenary. After a great deal of neglect, there is obviously enormous interest in health systems, and there are many forces driving that interest. I would like to highlight three. I think first is the recognition that disease-specific interventions delivered in very vertical silos have reached their limits. The second, of course, is the health worker crisis. And the third is the realization that this very beautiful, very profound vision of universal health coverage by 2030 will only be possible, says the WHO, by strong, people-centered primary healthcare with strong, resilient health systems that are rooted in the communities that they serve. And of course, this interest in systems has intensified further with the pandemic. COVID-19 has obviously put every health system in the world under pressure, and it also showed that the vulnerabilities in these systems can lead to, massive health, economic, and social shocks. So I think from the ashes of the COVID crisis, all nations have something to learn about building back better when it comes to health systems. It will not, of course, be easy. There will be stumbling blocks along the way. Perhaps three of the biggest stumbling blocks are: first, there still isn't a common understanding of exactly what we mean by health systems strengthening. It still remains a bit of a black box. Yes, we have the WHO's building blocks, the 6 famous building blocks of health systems: service delivery, health workers, information, medicines, financing, and governance. But does that really mean that if you improve one block, that is truly sustainable health systems strengthening? And how might we distinguish health systems support, procuring medicines, delivering bed nets, from true systems strengthening activity? Second, even if we could define health system strengthening, do we know how to do it? And third, of course, is the big money question. In a now famous study in Lancet Global Health, Karen Stenberg at WHO and colleagues estimate that an additional 371 billion per year is going to be needed by 2030 to strengthen health systems to achieve the health-related SDGs. So that might give us a bit of a sticker shock. Where is the finance going to come from? Today, we have a panel of 5 very remarkable people. They come from across government, multilateral development agencies, academia, and the people's health movement to help think through these very thorny issues. They have diverse backgrounds, experiences, and perspectives, but they share one thing in common. They have expertise in and are very passionate about health system strengthening and health systems resilience. So I'm tremendously excited to be hearing from them today. I'm going to briefly introduce the panelists. Their full biographies are on the PMAC website. Dr. Ariel Pablos Mendez, board certified internist. He is a professor of medicine at Columbia University Irving Medical Center. He was director of knowledge management at the WHO, managing director for international health at the Rockefeller Foundation, where he led the transformation of health systems for UHC in 2011, appointed by President Obama to lead USAID's Bureau for Global Health. Dr. Juan Pablo Uribe, Global Director for Health and Nutrition and Population at the World Bank, and director of the Global Financing Facility for Women, Children, and Adolescents. He was CEO of healthcare providers for United Healthcare Banmédica for Chile and Peru, and was Minister of Health and Social Protection of Colombia from 2018 to 2019. Prior to that, he was Director General of the Fundación Santa Fe de Bogotá in Colombia, an organization that works in healthcare, health education, and public health. Dr. Maris Jessa, an Estonian health expert, was most recently holding the position of top civil servant responsible for the health sector in the Estonian Ministry of Social Affairs. She also served as director of the National Institute for Health Development and the CEO of the Estonian Health Insurance Fund, and she has worked at the World Bank as a senior health specialist. Dr. Jessa served as a member of the executive board of WHO from 2009 to 2012. Dr. Yogesh Jain is a public health physician, founder of Sangwari People's Association for Equity in Health, and commissioner for the Lancet Commission on Reframing Non-Communicable Diseases and Injuries in the Poorest Billion. For the last 21 years, Dr. Jain has been primarily involved in comprehensive primary healthcare through founding and running a community health program. It's called JSS, the People's Health Support Group in rural Bilaspur in central India. And last but not least, Jan Willems Gijgrund is Vice President for Government and Public Affairs at Royal Philips, where he heads the global network responsible for relationships with governments and related stakeholders to address an array of societal challenges, including the impact of COVID-19 on healthcare transformation. He's also responsible for partnerships, such as with the UN and international development partners, that strengthen health systems in support of achieving UHC and responding to the COVID-19 crisis. He's also chairman of the UN Global Compact Netherlands. Welcome one and welcome all. So excited about the next 90 minutes. And I would like to ask Ariel to kick us off, if you will. What do you think, Dr. Pablos Mendes, are the critical steps that countries need to take right now to transform their health systems towards UHC, knowing that that is a process that will take time? What should they be doing now?
Well, a little bit of perspective is always important, Gavin. But thank you, Gavin, and it's great to join this great panel. And I think if you go back to 1978, it was the peak of the launch of the Health for All with primary health care, and but also coincided with the eradication of smallpox. So like this big vertical success together with the very energized primary care movement. And the history of our work on health systems, as you said, has been this balance of approaches. And so when you think of it, though, the geopolitical and the political economy was very different. Countries were very poor at the time. Countries were indebted, and there was we were just about to enter the era of globalization, and we were about to face the biggest pandemic of that time of AIDS, and so that dictated the tenor of the golden era for global health. Much accomplished, but health systems was not the priority during that period. This time things are different. We are entering a totally different political economy with the countries, and with a shift that was 40 years ago, the shift was moving from the state to the markets. Now there's a shift in social, political demand for social protection, and a shift towards a greater role of the state. And it's in that context that many countries are going to be addressing your question, what can we do now? Universal health coverage means access for all to appropriate health services without undue financial hardship to individuals and families. It is a top priority for WHO, in the SDGs, for the UN. And the good things, again, is that despite this recent crisis, which is not only health, but economical, there's growing GDP around the world that has been associated with increasing health spending and more human resources for health. And this is great for poorer nations. And At the same time, this rapid growth, as you know, often is paid out of pocket, which is very, very regressive, very inefficient, and a cause of impoverishment. So all of these challenges have been compounded as we try to build back better, stronger health systems in the aftermath of COVID-19. So what are those critical steps the countries need to take, Gavin asks, to transform their health systems towards UAC? Well, first of all, we need to realize, of course, that each country is very different, different histories, different resource levels, different political dynamics. There's no cookie cutter. And there are nonetheless many ways to skin a cat. So everything nonetheless requires political commitment, building on good primary health care, and aiming to minimize the out-of-pocket spending. USC is not new, and there are many models, as you know, from the 19th century Germans to post-World War II, UK national health systems, and there's a variety of options for countries. Oftentimes, countries already have some fragmented arrangement and they're trying to build, and it's very difficult. At the same time, I believe the key to universal health coverage not only is the political commitment, but also good governance arrangements and the financing. So stewardship and financing, in my view, are key to really drive the transformation of the health systems. With the recent economic transition, the fiscal space to finance USC will be growing by 2030. And even though the economy will be less than it has been because of the recent shocks, nonetheless, most of the countries will be able to finance their health needs with domestic resources, exception for only a small group of the poorest countries that will still require assistance. For example, a country with a GDP of 1,000 like DR Congo that consumes typically say 3% or $30 for health, that's not a lot. You cannot buy the basic needs, and those countries still need and other fragile states development assistance for health. As GDP grows to say $5,000 per capita like Cambodia, and they spend now 6% of their GDP in health, or $300 per capita, you know, now the challenge is how to organize those financing as they grow. They often grow too fast. They often grow outside the Minister of Health in the private sector, and it's a challenge of organization. For the richer countries, the headache is the opposite. How do you now control spending that is just too much for many of them, although that's, in my view, a fallacy. And so for those growing numbers, say Sweden with an income of over $50,000, health spending surpassing 10%, it's a different story, and yet is the same. You must have a strong primary healthcare systems. You must build, of course, public health at the same time, and you have to keep an eye on equitable and efficient access to health services. This law of health economics means that health spending will grow as the GDP of nations grow. And with many of the needs outside health are being met by growing labor productivity, health will be a beneficiary of those gains in the coming decades. And there are many fallacies, and so an understanding of the economics is crucial, is very crucial, and thus engagement of the World Bank as well as WHO is paramount in guiding countries as we move forward. I mean, health spending growth will not threaten the economic competitiveness of nations. We are here with many of the leading nations doing so. Health spending should not be controlled to try to keep it below GDP growth, because you will fail. Expanding health coverage does not necessarily increase health spending more and beyond what the economy will dictate. Paying out-of-pocket user fees helps bring total spending under control is a fallacy. We need to minimize it. Whereas in universal coverage itself may or may not be a single payer, may or may not be a publicly government run. There are many models to do it, and we just need to make sure that the various options of how to get the revenues, how to pool the resources, how to purchase the services is well done. The challenge, of course, are vested interests. There are many vested interests in systems that evolve in the jungle, as I will put it, really in the wilderness. And so we need to be able to have the political wherewithal to address those, and the cleverness to address those. Resources will not shrink, so it's a matter of planning the future better to transition segmented and fragmented systems into what Julio Frank calls structural pluralism. So I think the countries have a lot to do. I was involved with the World Health Report in 2010, and the actual nitty-gritty of the work involves systems designs, legislation, the financial architecture, then the enablers, IT, and so on and so forth. So in the end, all of this is doable, is being done. There's the Joint Learning Network for Universal Health Coverage that is sharing about exactly those lessons, how do you do it. And while donors will not be buying the health insurance of all countries, but indeed only provide technical assistance and cooperation, donors may actually buy the cost of the transitions, which may be 2 or 3% of the total spending of a country over a period of 4 or 5 years. So there's a lot that can be done and is being done around the world. More than a third of the world already have universal coverage. Another third is being really halfway and getting stuck as the taxation has to go up. And then there are many others who have been the traditional recipients of donors' aid that will need a lot more to design the health systems. And paradoxically, in poorer nations, it's probably easier to help bring that design before vested interests make it so hard, as we are seeing already in South Africa, Nigeria, and so on.
Thank you for laying out the steps so clearly and so beautifully. You've already raised so many issues around the financing, around the governance, around the political will. I want to move to Juan Pablo Uribe on the financing side. Earlier, I gave a famous estimate from Karin Stenberg on the financing needs. Ariel has given a sense of how financing is likely to grow as countries' GDPs grow. What are your suggestions for financing health systems and health strengthening to make them more equitable and responsible to the most vulnerable populations and communities?
Gavin, thanks so much. I want to start by expressing my happiness being here in PMAC again and joining other panelists. Hopefully next time it's going to be in presence. I think we all need to stay very optimistic, keep a smile on, and do our best work as we meet again, hopefully again very soon. Look, the financing part, and as Ariel was saying, it always has been a huge challenge for health systems in the practical world, in our middle and low income countries, but also in high income countries. There has always been permanent financing pressure. Different ways of approaching it, as Ariel said, very country specific, depending on the structure of the health system, depending on the priority of the health sector within the country, depending on so many other things, like the same economic and employment infrastructure throughout the country. But I just want to highlight that COVID has made something that was challenging now incredibly more challenging. We all know as we come out of this pandemic that countries will have a shrink fiscal space. They will have much less resources, and at the same time, low and middle income countries are going to be facing increasing needs. So this is really a situation that we need to acknowledge as we ask health systems to do so many things at the same time coming out of the pandemic. We finished in the bank recently a study called From Double Shock to Double Recovery, looking precisely to something that Ariel was pointing out. It's the government spending and the capacity of per capita health spending in this recovery phase that we're all hoping to walk into soon. And what the study shows is that for more than 50 of the countries given, more than 50 of them, the resources available, not in this year or in the following, until 2025, resources available are going to be less in terms of public per capita health spending than what they had in 2019 before the COVID struck. So really, we're going to be having to do an incredible effort moving ahead. What can be done? There are no secrets here on the what's. They have been published and researched and presented and sustained for many, many years. We need a financing system in our health systems that is sufficient, for the expectations and needs of the communities it serves. We need it to be equitable. As Ariel said, reducing out-of-pocket expenditure, reducing poverty out of health shocks, and securing access for all in an equitable way. It has to be efficient. It has to be allocated in the proper way, accountable, transparent, reaching the objectives the financial flows are intended to facilitate. And it has to be effective in the face of the population that it serves. People need to see that that financial effort is really bringing the services that they are expecting as citizens. So it's a huge expectation on financing systems. And the blocks to work are also very well known. We are talking a lot in the bank about scaling up what works, looking carefully, for example, into taxation, and health taxes are again in the agenda. Looking overall into government spending and the priority health has within government spending, aligning international assistance, of course, when that's important in a specific country space, focusing on human capital and trying to change this discussion about health as an expenditure, which is so frequent, for example, in the Ministers of Finance table, to what we saw with the COVID, health investments as a needed priority for human capital return in the short, medium, and longer terms for our societies. And we need to do that with a longer term vision for our health systems. Coming from a particular health system and from a leadership position in it, I think there was nothing more important than being able to discuss a long-term vision for our health system in my country. So many stakeholders with so many different interests, so many competing needs, so many distractions year by year. It's critical that countries really set a long-term vision for their health systems that, again, enable them to have a roadmap for a health system and a financing that is sufficient, equitable, efficient, and effective. I would like to finish there with something that Ariel also mentioned a couple of times, and I guess, Gavin, that we're going to be coming back over and over again into it. And it's the governance, the organization capacity, and the leadership in our health systems.
Yeah.
Without that, it doesn't matter that we go and do the biggest financing effort that we can in each one of our countries. We need governance arrangements that really care for the systems and for their objectives at all levels. We need to strengthen the organizational capacity in following results, in following financial flows, in caring for people, caring for that workforce that you spoke at the beginning. And we need very strong leadership at all levels. It's not only at the highest state level or the ministry. We need strong leadership in each and every hospital. Doesn't matter the level of complexity. We need strong leadership in the communities and in the community health centers. We need strong leadership in health because we have a huge challenge ahead and incredible expectations. Over to you, Gavin.
Thank you very much, Juan Pablo. Actually, I've got a question which will come up later about something you said, which is on leadership. Emerito Jose Paraun notes that we need leadership at all these levels. Emerito says they need to get their hands dirty in planning and implementation of health service delivery at all different levels. So I'm going to come back to that when we chat as a panel. Lots of questions coming through on how you kind of build this political will, how you drive this political will, and how you generate it. So I want to come back to that in a few minutes. Juan Pablo, thank you very much. I want to turn to Maris, and I want to talk about primary healthcare. I know we're all passionate about primary healthcare. In your opinion, what has been the role of primary healthcare systems during the pandemic?
Hello to everybody, and thank you for the invitation to share the experience as well as lessons from Estonia. Firstly, we cannot detach primary care from the whole health system. Health system works when it is comprehensive. Having said that, primary care in the Estonian experience has really delivered in the Estonian response to COVID. Without the primary care system we had built over the last 25 years, we would not have been able to continue with services to the people when hospitals were overburdened with COVID patients, as well as, more crucially, we would not have been able to deliver quick vaccination when vaccine became available in Estonia. However, it is useful to share some of the more comprehensive experience we had with COVID response from Estonia. As we have a global audience, just a few words where Estonia is and how our health system looks like. We are a rather small Eastern European country. Primary care is delivered by family practitioner teams who are private. Hospitals are mostly public, delivering both outpatient as well as inpatient care. Separately standing outpatient providers are also private. We have a social health insurance system and we are fairly well digitalized. The overall COVID response in Estonia was tried to balance the restrictions with not overburdening the health system. So we never went into total lockdown. People were never confined to their homes. However, there were instances when the balance was really on a knife's edge, and once we dropped over and there was a crisis in the hospitals, which was exactly 1 year ago. So we were not hit by the first wave, but rather in the second wave. Through the 2 years, primary care has been the level of health service delivery, which turned very quickly into adopting more telemedicine, distant advice to people. This was helped by the infrastructure in place. The prescriptions, a dominant way of prescribing medicines in Estonia has been electronic prescription already over 15 years. So both providers as well as people were kind of more used to the the distant advice and distant consultations. In hospitals, as I said, we were hit exactly 1 year ago. The biggest challenge was staffing, when there was a need to increase the COVID treatment capacities. Although the plans were in place, still staffing was a challenge. How to reallocate the staff to COVID wards, how to get extra staff to the hospitals. It took doubling of salaries offered in the COVID departments, what was the crucial point. What was also good was that people from private sector volunteered to come to work to the hospitals to help with the burden. What we also employed was reallocation of patients between regions, because regions were hit differently. The disease burden in different regions was different. And lastly, on vaccinations, Estonia is a member of European Union. Therefore, we had access to the vaccines fairly early on, already in the last days of 2020. And I want to reinforce the importance of functioning primary care, which covers whole of the country, where it was not self-evident that people, especially risk group people, really want to be vaccinated, because the hesitations were there on the questions were asked about the speedy development of the vaccine, the new technologies used for the vaccines which were entered first in the market. And we made the decision to deliver the vaccine as close to people as possible, which means the widest net that you have, it's the primary care centers, the family doctors. And secondly, that the survey showed that the personal, family doctors, nurses are the best trusted by the people of risk groups especially. So we really they made personal phone calls to their patients, inviting them to be vaccinated, and this was behind the early success we had in the very first months. And concluding 6 issues that that were perhaps lessons learned and thoughts for the future, how to manage these. And firstly, again, primary care really delivered, and it is necessary to maintain a network of primary care all over the country, physically present as much as possible. Second, which is an issue for the future, flexibility in staffing, how to reorganize services within healthcare providers and between healthcare providers when you are faced with crisis. Thirdly, pandemic response needs continuous training, needs dry runs, drills, in order for the skills that we have now acquired, that these would be maintained in the future. Yeah. This is something I must admit we neglected in Estonia. We are having dry runs for major traffic accidents, how to respond to those, but not to how to respond to pandemics. Fourth is an issue of the drive of maximum efficiency, how health systems should be operating. This is what we have been doing for the last decades. How the health systems would run at maximum efficiency at the time of peace. However, if we are running at maximum efficiency at peacetime, where do we get the reserve needed to make the extra effort when the crisis hits? And especially if the crisis is not in one region and in 1 month, 2 months, but it is a prolonged effort of response, like it is with COVID now already 2 years. And this is something that clearly we need to be addressing. What is the aim of efficiency we want to achieve during the peace times? Penultimate lesson: extra funding helps. Without extra funding, you cannot get crisis response out from the health system. And lastly, my last remark is on the digital and technological response and tools. We had the infrastructure in place and it was invaluable. However, we need to remind ourselves that there are people who are not using digital services. There are more people among the population, but there are also a few providers who are not so technologically advanced. And we need to keep them also under attention and to so that nobody will be left behind. We need to keep also alternative solutions up and not go only fully technological, fully digital. With this, I conclude, and apologies if I ran over time. I tried to keep myself timed. Thank you.
Thank you so much. Thank you so much, Maris. So many reflections. Just a couple of things I wanted to respond to. One is, I talked at the very beginning about health systems being rooted in the communities they serve. And I think you demonstrated that very powerfully with the phone calls to people who need to be vaccinated because they're high risk. My colleague here at Duke, Lavanya Vasudevan, who's a social scientist, has spent her career looking at building confidence in vaccines. And the number one factor in her research is whether a trusted provider, a trusted primary healthcare person, builds a relationship with the patient and explains why they themselves got vaccinated or they vaccinated their kids and shares that. And I think, we cannot overestimate how important that bond is. And the other thing I want to just plant a flag and come back to this when we chat as a panel, this question of, having a reserve, having some slack in the system, building resilience. What does that, I want to come back to the panel to ask kind of, what does that look like? And how do you develop it? Dean Jameson, health economist that many of us know, always talks about pandemic preparedness as really requiring surge capacity, not just being able to surge vaccines and surge vaccine manufacturing capacity, but surge people. And I think that's a really important element that I wanted to come back to. Thanks, Maris. I want to turn to Yogesh. So I just mentioned a people-centered health system, and this is something you have deep expertise and deep experience in. What does it mean? What does it look like to have a people-centered health system? How do you achieve it? What are the challenges in achieving such a vision?
Thanks, Gavin. Your question begs the statement that health systems in most countries are not people-centered. People's needs are not addressed. Often their desires are not considered by the decision makers. And it seems something else is more important when, in terms of centering health systems, as the experience shows. Maybe it is the profits by the people who are in the private sector, or that some people out of all the people that are at the center of decision making. So from the experience in central India, which I would argue would be one epicenter of inequality or marginalization in the world, I would say I would look at these suggestions in form of either overall some suggestions or in components of health systems. Overall, I would say yes, a well-funded system is necessary, without which you cannot you can't do any centering, and I would say. I would argue for a 70% ring fencing for funding for primary care out of all the funds, particularly when funds are in crunch. Secondly, I would strongly argue for a publicly owned and publicly provided healthcare as a predominant health system, and private sector, if at all, playing in some minor role in most unequal countries of the world that I know of, and obviously primary healthcare oriented. The problem is, an overall problem is that how do we inculcate an attitude or ethos of people-centered service among service providers? But I also believe that once the reason for the lack of favor of such an attitude is identified, it can be addressed. But if I look at the components which at specific components of health systems that could be basis of centering systems around people, my first would be for the HR would be the larger recognition and support for non-physician health workers all across health systems, and particularly at the primary care level, and then appropriate training and mentoring for them at an individual level or at a group level. For example, mentoring as a principle of supporting health systems is not just there in most systems that I know of, and I think that has to come up. Institutionalizing systems for team and individual mentoring has to happen of the entire PHC workforce, without which people are left to their devices and the systems are hijacked almost. And I would argue for specialists in family medicine could be considered to lead and support primary healthcare workforce teams at both primary and secondary levels, and not allow them to be handled by specialists in only domain specialists. And as one example of communitizing healthcare, where people centering could be possible, is to run, at least in the care of NCDs that I know of, peer support groups, where people who suffer from an illness can be together, meet once a month, and support their problems, the care of their own problems, and taking away the power, in a sense, from the hospital and the physicians. And I would say in HR, one other suggestion would be as that has been borne out of experience from China as well in my Kerala, in my own country, that non-health workforce should also be trained in healthcare literacy. As I would even argue for that, even civil society partners which are not working in health should become healthcare literate, and they can do many other things in healthcare delivery, which are not just niche pills and operating. When it comes to some staff issues, I would argue for a well thought out role for information technology. Digital technology should be used to train and mentor and provide clinical guidance, but and mainly to provide the quality of service delivery, but not to police them, is what I would argue. And digital health interventions should be selected so that they can complement one another and maximize the effect of the primary healthcare system. They should improve the essential public health functions. We should not go for the health medical record systems should be interoperable, and finally, these issues in using technology should also be allowing data access, sharing, consent, and cybersecurity, which I think are important. In terms of systems, I would otherwise also argue that we actually have to develop a culture and actually implement it of listening to the people and dialogue with them, having a seat on the table for them, people who actually suffer the problems, rather than have a system where people who decide don't have a skin in the game and they don't suffer the consequences of their decision, and people who suffer the consequences of health systems being determined for them don't have a voice in it. And I would argue for local level village health committees. A formal structure for receiving people's consultation from the bottom to the top should be done, and this is doable. There are ways that has been done in the past. In terms of challenges, I would argue that the hegemony of the physicians and the hospital as the infrastructural locus, and as well as of the planners who are not held accountable, is a major thing that we need to break, because this has been also supported by, at least in my country, the Drugs and Cosmetics Act in India does not allow non-physicians to prescribe or dispense any drugs except a few over-the-counter drugs. And this is not possible to provide primary healthcare with such a regressive, legal hurdle. And the other challenge I would say is this over-enthusiasm regarding information technology and other instrument technology, where artificial intelligence is considered better than natural stupidity or natural intelligence, as well as there is also a problem about health rights literacy in the country that at least India is, as I'm sure that's true for other places. The other challenge is it's a very slow process to make people-centeredness in healthcare, and it's also difficult to measure. So I would say these would be my suggestion for the challenges. Thank you.
Thank you so much. That's a very powerful vision you set out. I was very excited to hear you talk about peer support, which I think is something that's going to become increasingly important over the future. I'm very taken by some of the research, including randomized trials on women's peer support groups during pregnancy and how they have been associated with reduced maternal mortality, newborn mortality. It's very powerful. Not everywhere, in every setting, but I think it does certainly signal something that we are probably underusing. And I want to come back to so many questions in a minute. I want to finally turn to Jan Willems Heigrund, and I want to segue to think about the private sector, obviously a large sector in many health systems. What do you see as the role of the private sector in health transformation, in health systems as we go forward?
Thanks, and thanks for the invitation. Good to be in the panel. Now, the private sector is already playing a very important role in this sector and will continue to play a very important role, but I hope it's going to be a different role thanks to COVID. Now, if you look at society and healthcare, about 10% of the economy in any country you look at is healthcare. About 10% of the workforce is healthcare. About 10% and probably a bit more is government spending on healthcare. So of course, the private sector is part of that in many, many, many different ways. But what we learned during COVID is that that role is changing. And the private sector has to ask itself, what is the role that we play? Now, I would like to think of the private sector as the kettle drum in a orchestra. You know, the kettle drums, they can, if they play alone, they are expensive, noisy, and just very annoying. You know, boom, boom, boom. Yeah, but in a symphony orchestra, they are valuable, powerful, and beautiful. So in that symphony that is going to create that new healthcare system, we have a very valuable, powerful, and beautiful role to play if we draw upon the lessons from COVID. And what did we learn from COVID? During COVID, the private sector was being called upon by everyone. And that was easy because we had a joint sense of purpose. The purpose was get rid of this pandemic. Everybody on board, private sector, come on board. So in that purpose, we created new partnerships that were not there before, strong partnerships to deliver on that purpose. And we had to trust each other. There was no time to get to know each other, to understand the governance mechanisms of our partnership and see if we had ways of working that have been tested to time and friendship and all that. No, trust was implicit. We had to trust upon each other in this crisis to deliver on the purpose of eradicating the pandemic. Now, and that created a lot of innovation. There was a massive amount of innovation going on, radical and disruptive in an inherently conservative sector, the most conservative sector on earth, if you like. So what did we learn from all of that? That innovation in logistics, that innovation in personal protective equipment, in keeping airlines going with medical equipment, vaccines, tests, medical equipment, but even people in hotels and stewardesses trying to be trained on treating patients in no time. It is that sense of partnership, that trust, that common purpose, and then that innovation that can unlock. Now, in designing that new health system, I think Ariel already said that, we lack that common purpose because we do not know what that new healthcare system of 2030 is going to look like. We have the SDGs, we have indeed the 6 pillars of the WHO framework. But even in the country where I live, the Netherlands, the Dutch government has only started 2 weeks ago to design a future plan for healthcare. Now, when I spoke to the OECD and other partners, many countries are not thinking about that future yet. The only thing they can say is, yeah, we need a resilient healthcare system. Let's go. If you don't know where you're going, any road will take you there. So we need that common purpose, that new definition of that resilient healthcare system. And in that search of an organization that could do that, I stumbled upon the World Economic Forum that had identified this need a bit more than a year ago, together with the London School of Economics and AstraZeneca, who said, look, as we come out of this crisis, what direction are we going to go, and what's the role of each of us, including the private sector, in coming to that resilient and more sustainable healthcare system that is making us ready for the next pandemic, also dealing with the healthcare inadequacies that we've all found in the context of the long-term problems like NCDs and financial sustainability. And the London School of Economics has its massive global academic partnership that allows them to develop a framework to measure the resilience and the sustainability of healthcare systems. The World Economic Forum is the largest public-private collaboration in the world, has got that trust as a partnership to bring partners together. And what they've done is develop that mechanism, that framework, if you like, to measure the resilience and the sustainability at country level, dialogue with the various stakeholders, under the guidance of the academics, and including the politicians, and help them co-create and create and map out that roadmap towards more resilience and sustainability. And a number of areas that came across already in this presentation as well are, we see indeed there is a massive change needed in governance. And the question there was, we've seen in several countries, and last year they did 8 country assessments, countries like Vietnam and Russia and Poland and France and UK. They found governance indeed a big problem. The barriers, the gaps in decision making, the fact that politicians don't stay on long, that there's no multi-year planning or no multi-year financing, that laws are being changed time and over again, not giving the stability and the quality of decision making. Finance, and I'll come to that later. Finance is not wrong. If you are focusing on customer needs, your financial mechanism should be a way to allow you to meet the patient or the customer needs. But if your financing and your customer needs are misaligned, you get the wrong things. So we need that realignment of financing, that modernization of financing to be aligned with the customer needs. And then, of course, the other pillars, I mean, digitization is going to be a big, massive transformer of everything, and depending on how you want to use it. And in particular, how that's going to impact service delivery. We talked about the role of primary healthcare. How is digitization and a different governance and financing mechanism going to improve service delivery so that it's all about access what is close to the people? So it's the geographic access, it's the social access for the people that are left out, it's the economic access for those that can't pay. So the access to healthcare, and we see that already around the world, is massively changing because of a different way of organizing your healthcare system and the digitization. And then the workforce. How do we stop them from being burned out? How do we keep them motivated? Why are people leaving the healthcare system in this COVID crisis? Hey, there's a sense of purpose, right? Why aren't you coming into the healthcare system? They're leaving because it's too much. So somehow we're burning them like consumables. We should be investing in the people, reskilling them, motivating them, continuously upgrading their skills. And then finally, the role for technology medicine. Now, as Philips, as a technology company, we see a massive change towards SaaS, software as a service, cloud, artificial intelligence. Yogesh was already talking about the Maris as well, with all their opportunities and risks, data protection, privacy, cybersecurity, cyber terrorism, etc., bullying, as we saw in the video. But we also see the transformation of pathways, and let's keep in mind operational efficiency. It's boring stuff, but if you know that 25% of healthcare is waste, there's so much to be done by increasing transparency of the healthcare system and addressing these operational inefficiencies that we see everywhere. But most of all, I think of all these changes, we are going to move away from healthcare to health and well-being. So the preventative side of it, now only 3% of the cost of the spend of society, soon hopefully much more of an investment so that we can start working about the healthcare or the health of our populations rather than the care of the few sick ones. Thank you.
Thank you so much. Questions are flowing in. I want to turn to them and actually just bring everybody on the panel into these questions. One is one that I flagged already that I was really hoping to ask all of you. Everybody today has talked about political will, but what is it and how do you actually develop it? How do you generate it? If it isn't there, how do you make it happen? And this is a question that many people have posed today. It's obviously a predictor of strong health systems or health systems that are going to be strengthened in the future if there's political will. I would love the panel's reflections on this question of what it is and how you generate it. Who would like to kick off? Ariel, I may put you on the spot.
Well, I've always been of the idea that crises are opportunities, and so that's been the case so many times. And the history of universal coverage is very much that. I mean, the German model came about because the Kaiser was being challenged by the new and strong labor movement, and were about to lose the election, and they invented Social Security and won the election. The UK, which is not known for socialism, nonetheless, once their country was destroyed by World War II and London and so on, and pretty much the government through the military and the Red Cross had taken over services, came about with the solidarity to bring together and create the national health system. We also remember how Thailand itself were one of the greatest health systems, and the community universal coverage came about at the depth of the financial crisis, the turn of the century. And so again, I believe all countries should take the challenge as an opportunity. This coincides with this larger shift in the pendulum of history towards a greater role of markets. in the stewardship and financing, although the provision can remain public and private. And it would require a lot of cleverness and invention and in the stewardship, as Marisa has already illustrated in Estonia. At the same time, the response, although has to be rooted in primary care, I always remember that Uganda has seen over the last 20 years a consistent decrease in the number and impact of Ebola outbreaks. We don't even hear of them in Uganda because our primary care has been so good at it. But in the end, outbreaks will happen here and there. Probably we will not see another one like this one in our lifetime, but there will be many others and they will be disruptive and so on. And the best way, in addition to having a strong health systems in countries, is to also have supranational systems, supranational public goods, both on information management and stewardship and leadership, in procurement, in the R&D, and even in SWAT teams that can go and address, because this is not wise to try to build full capacities in every country for something that will cool off. Believe me, people, I remember in Washington, there's a lot of attention and budgets, and then everything goes away after the outbreak goes, even for this one. And so use jiu-jitsu, the current attention to help to do better, but also be prepared to the fact that that will just wash away, build those more efficient supranational systems, and also address the One Health dimensions beyond the health sector that matter a lot for zoonotics as climate change and urbanization in Africa and elsewhere.
Thank you, Ariel. Maris, and then Juan Pablo.
I think that the political window does open up from time to time. And whatever the situation, criteria, context is, but there comes a leader in the health arena who is kind of, who wants to drive decisions. In the Estonian case, we have seen it happens once in a decade. Is somehow when I look at the Estonian health reform timeline. However, this is not enough when the kind of political window opens, because the political window can close also very quickly within a year and a half, 2 years. And therefore, it is necessary that for the time when the window starts to open up, that you have the analysis in place, you have the proposals in place, you are able to offer solutions, alternative solutions to the politicians, and this is something that needs to keep going continuously in the civil service, in the academia, with the providers, that you have to build the consensus on what is the aim, what do we want to achieve, what are the alternatives, and then when the political window opens, you can go for decisions, and it has to be done fairly quickly. Is my experience from Estonia as well as from some other countries. Thanks.
Thanks so much. I teach a class on global health policy, and we talk a lot about windows of opportunity and jumping through them when you see them, and being entrepreneurial, policy entrepreneurs who can spot the moment to act. I think, obviously, with the pandemic, this is a crisis, but there, as Ariel has said, there's also opportunities that I hope get jumped upon. Juan Pablo.
It would be great if we had an answer, Gavin, to your question. And if we could scale that globally, just imagine that, it would be beautiful. But as Hans said, we can do things. I think they're all incremental. And I have here a list in no particular, let's say, order of things I would try to bring into that construction of political will around health systems and primary health care, etc. One, again, is building the case that we're talking about an investment in human capital with great returns and not only an expenditure. And we need to make this in an easy way. To a certain extent, the health sector has been very isolated because it's extremely technical and in a way inward looking, and many people try to stay away from it because they say it's too complicated. I don't understand what you're talking about. So they stay outside of it. So make it more inclusive, more around people, around human capital. Second, bring all the cross-sectoral relations that it has and make them explicit. When we're talking about health, we're talking about infrastructure and water and sanitation and agriculture and animal sciences and climate change, for example, and environment. And I think that makes us more attractive for that political will. Third, we are a great employer. The health sector in our countries employs hundreds of thousands of people. It is people-driven, not only people-centered. So I do believe that we should also look for that political will and support, presenting ourselves as part of the solution, even in that job creation moving forward and the fight against informality, which is going to be so important, and against poverty in the coming months and years. Fourth, I would say, and I would build a case, Jan William, around the capacity the health sector has to bring research and innovation at all levels, not only in high-income countries, in low-income countries. This is a sector that can push the frontiers in many areas of societies and of human development. And finally, very associated with it, it is a space for private sector growth. And if properly regulated, the power of private sector in pushing the development and the well-being of societies is incredible. So I would bring those 5 elements also to the discussion, trying to make ourselves, again, more attractive for that political will in sustainable ways.
Wonderful. Thanks, Juan Pablo. Yeah, Williams, just since the private sector was just mentioned, I would love you to reflect on that in terms of what's the role for the private sector in building political will around health and health system strengthening.
Yeah, look, political will is important, but it's not everything. And I think that we shouldn't wait for political will to transform the healthcare system. And I think that there is an innate and intrinsic motivation of the whole healthcare system around the world to draw upon the lessons of COVID and continue that transformation that was started during COVID. We see that everywhere. And they're not waiting for political will, because I do recognize the risk, and I do see that we need to make the sector more attractive and interesting for politicians. But we've seen incredible creativity, and to Juan's point, research and innovation happening. We've also seen that, especially now that the whole society is digitizing, and not only in healthcare, but in all sectors, that a lot of politicians are looking at a sector that creates trust of their population, that as a justification for the digitization of society. Now, maybe Maris can say a little bit about that, but for example, the European Union is investing 1.8 trillion euros in the recovery and the resilience of its economy at large. And a large part of that has to be digital. And a lot of people are still a little bit afraid of digitization, right? And what does that bring? Am I going to be left behind? Is it safe? Are you going to watch me? And so what you see politicians do is say, well, okay, well, let's use healthcare as a reason why we need to digitize. As a good example, look, we need to digitize because we need to improve the quality of care. We need to have affordability, telehealth, etc. And then people say, yes, I get it. So I think for us, there's an opportunity to help the wider digitization of societies that are on that path, and bring politicians along to feel more comfortable about the benefits of digitization. But also, healthcare data is the most precious data in the world. It's more precious than your financial data, your economic data, or any other data. So healthcare is the most precious, and needs to be protected best. So if you design your digitization around the securities that you give your populations around how we treat your data respectfully, with for privacy, securely, etc., it may actually become that catalyst for a wider digitization that so many also of the developing countries are now trying.
Thank you, Jan Willem. I want to turn to Yogesh actually, because digital keeps coming up, and Yogesh, you actually have mentioned digital, potentially also for reaching remote communities, rural communities. And we've had a few questions. Nichapa Padcharon asks about the digital health transformation and its contribution contributions to health systems in the post-COVID-19 era. I would love your thoughts on this topic, Yogesh. Yogesh, you are still on mute. Someone always has to be on mute. There you go. No worries.
Sorry. It is important. It is useful, provided it is used to improve systems, and therefore there will be a country context to it, and to improve the care continuum and referral systems. Yes, there is a great role that it brings in, bringing specialist care closer to people, closer to the frontline workers also would be great. And it also can reduce patient hardship. But at the same time, and it can also get in diagnostic technology also close to people if we somehow use it well. But it should not be at the cost of abandoning physical examination, as well as unburdening the physician community from visiting the communities at large. There is this risk that we have seen, that people now feel that they can now provide all healthcare sitting in their own, in their cities or city offices, and not go to the community at all. This is a problem that we have seen in India in a big way, and so I would say that we should use digital technology with kid gloves, and it should not be used for policing the people only, but for supporting the communities at large. As well as the peripheral workers. So I am with that caution.
Yeah. Thank you. Jan Willem, I see you have your hand up. This is obviously your area.
Yeah, for a very small comment, Yogesh, I fully agree with you. We say digitization should enable high tech for high touch. So not a replacement of the physical exam, but intensify the physical exam possibilities of an innately personal profession.
Yeah.
There are some wonderful questions here, 4 or 5 that I would love us to try and get through before this panel finishes. One question has come up from several different people, from Zani, from folks in Myanmar, from folks in Burkina Faso, and it's about fragile systems, conflict nations, post-conflict nations. Zani, for example, says, how can we build health systems in fragile states like Myanmar and Burkina Faso? How should we be thinking about health as a bridge to peace? Lots of questions about fragile states. Our center, Duke, just finished a paper with a study with WHO EMRO on pandemics and vulnerable and fragile states. And clearly there are some themes that emerge around community engagement, around diplomacy and using diplomatic moments, again around the value of digital and so on. Does anyone have any thoughts and reflections on this very specific question of how to build and strengthen health systems in these challenging conditions, challenging settings?
I don't have a lot of experience to really do that, but at the global level, I have to say that that's recognized as a priority, and there's in general greater focus and attention, so the resources will be more devoted to those areas. In many places, for say the U.S. government that cannot work in certain places because there's no embassy to oversee programs accountably to Congress, taxpayers, and so on, then you have to work through UN systems. So I would say NGOs and UN systems who are already on the ground are a good way. Sometimes governments are reliable or moving or shifting. So I think the UN system on the ground is a very important piece for global governments. I have to say that Western Africa as a whole is an area that has been underfunded relative to the burden of disease for maternal child health in particular, and that because of part of these reasons, the resources have not been able to arrive, but we have to be clever into bringing resources to those areas. For other places, it may not be, they're more visible, but West Africa somehow is invisible, and that's where kids are dying.
Thank you. Juan Pablo.
I would only add the importance of prioritization, and we're talking about very essential services and really focusing on those. And in that focus, working in the front lines with the human resources, it's critical everywhere, but in particular in those settings.
Yeah, I mean, just a reflection. We interviewed a lot of frontline health workers in places like Syria for this study, and it was really amazing to hear these folks are literally putting their lives on the line every single day, and they're doing things like trying to achieve vaccination ceasefires or mask ceasefires. It is honestly, you know, as a researcher, you're supposed to sort of maintain objectivity. But at the end of every interview, I just said, look, I want to take my researcher hat off for a minute and just say, thank you for what you're doing. It's really absolutely remarkable. I think we have to recognize that. You know, you talked about prioritization, Juan Pablo, and there's a really fantastic question about how if you cannot provide all services to all people, and yet you are striving for universal health coverage and sustainable health systems, where do you begin? I mean, do you prioritize certain groups of people? Do you prioritize certain interventions? How do we think about this pathway going forward in a way that's fair and equitable and efficient and just?
Okay, I'm going to refer to a personal experience, and it's to the case of the Colombian health reform in the early 90s. But very briefly, the dilemma was between, with limited resources, as always happens. Do you go for a very generous health benefit package, focus on the poorest, or do you try to have a more prioritized and reduce health benefit package that reaches everybody and then is gradually increased as the fiscal space and the solidarity mechanisms, etc., work? The first was much more attractive in terms of targeting immediately, much more at-need people, but it created a terrible policy dilemma in terms of the support for the reform overall. So would other people still contribute? Would evasion and elusion increase because we were not reaching everybody? At the end of the day, we went for a more basic, it was not basic, it was very generous, by the way, but let's say a smaller health benefit package that immediately started reaching everybody with very targeted solidarity and subsidized mechanisms for the poorer, but where everybody felt that they were part of the system. And then increase it again, maintaining targeting mechanisms and a lot of those solidarity financing instruments as well. So I'll stop there because I think the choice depends a lot on the setting and on the political system that you want to strengthen and develop through time.
Thank you very much. The conversation today has obviously been at the national level and subnational level, where health systems happens and where health system strengthening happens. But Valeria de Oliveira Cruz asks about the global health architecture to support health systems. Do we think it is fit for purpose to respond to health system strengthening needs in pursuit of UHC by 2030? And if not, what changes do we need to the global health architecture? This is a question that keeps coming up. Obviously, in the pandemic era and hopefully the post-pandemic era, there's a lot of conversations happening around the global health architecture and how it might need reform and whether we need innovations and whether we need pandemic treaties and so on. Any reflections from anyone on the panel on this question of the global health architecture? Juan Pablo.
So I'm going to be very brief because I just spoke. So I just wanted
to bring
two elements to the discussion on this very good question. I would say one thing that we're all looking for globally is harmonization. I think life would be easier for everybody, and in particular for lower and middle income countries, if we can come out of this, let's say, global architecture with much more harmony in the responses. And I'm talking about everything there. Talking about the agreement on distributing the vaccines. I'm talking about research and development and manufacturing. I'm talking about protocols that have incredible impact on what several countries and not in others, etc. I really believe that we need to globally act with global responsibility and much more cohesion. And that said, I also want to bring a second element. It's not only global. I want to just highlight, Gavin and other colleagues, the importance of the regional scope in pandemic preparedness and response. We've seen the immense need and the immense benefit of regional agreements working on many of these risks and on the solutions. So Africa has brought an incredible example, for example, of regional mechanisms in place, and other regions are now looking at that in order to follow. So regional is also very important, again, in this question that you posed. Over.
Yeah. My own students always ask me, what do you think of the future of global health? And I say it's regions, regions, regions. I mean, look at Africa's CDC and John Nkengasong's remarkable work. Look at, the African medicines agencies, the regional vaccine production efforts ahead. I think that's going to be where the energy may be moving from, away from DC and Geneva towards the regions. Jan Willem, you are on mute.
Incredible.
There we
That
go.
happened to me. Sorry. I fully agree on that regionalization need. You see that indeed happening also in the European Union, for example, that the European Commission not having a mandate for healthcare, but now taking a better control with the European Center for Disease Control and also the preparedness, the pandemic preparedness role. But I would hope that also the global governance would be strengthened. And I'll say that as a user of global governance in the private sector. During the height of the COVID crisis, we had as Philips, we produced a lot of ventilators, but also patient monitors and ICU equipment. And of course, there was not enough for everybody that wanted it. And so we asked the global healthcare players is, okay, who should go first? Who should we provide? Is Mali more important than Germany or the United States? And the individualism and the greed, and if you like, the power play between the countries was just shocking. It was truly, it's like me first, me first, me first. Even in the countries where we thought that they would never be like that. And I know that Tedros has been calling for fair allocation and solidarity, even on the vaccines and all that. But we've seen the medtech producers, and Philips was not alone, engaging with WHO and with the World Bank. How do we deal with this? How do we prioritize? How do we help the ones that really need it instead of the ones that really can pay for it? And that global solidarity and that fair allocation role is I think, most critical to solving the global governance. Because today, and still today, it is the companies themselves that have to create their own ethical frameworks to say, you first, you country, this country first over that country. And the countries themselves do not make that decision. So that's a lack of political leadership. It's a lack of global governance that needs to be urgently addressed. And I don't think it's getting enough attention as a driver for that change. Who gets to answer who's first?
Thank you, Jan Willem. Maris.
On the whether we need a new global health architecture and also on regionalization, we would need a major reform of the global health architecture if we found, if our evidence at the moment suggests that the current architecture is fundamentally flawed. I don't believe that we have gotten this evidence from the 2 years of crisis now. So rather, we would need to work with the current global health architecture to make it more workable, to address the flaws in it, rather than go for a whole new approach. And this is I'm saying. From my experience at the executive board member of WHO, when WHO launched major reforms in a decade ago. On the regionalization, would voice a little bit different angle than the previous speakers agreed that we should do much more as countries. We should do much more regionally. However, what I have experienced is that as countries, we have much more lessons to learn in countries from different regions than necessarily from our own regions. When Eastern Europe started with health reforms back in 1990s, early 2000s, then the Eastern European countries had much more in common with the challenges of Latin American countries than with the Western European countries. And I regret it very much that WHO does not work as much across regions as, for example, the World Bank does. So therefore, when working more within a region, we should be working also more cross regions, specifically with countries who have similar challenges than us. Thanks.
Thank you very much. We've got about 4 or 5 minutes left. Oh, Ariel, go ahead. Quick comment, and I'm going to try and see if we can get to one more question.
Right. I think I'm on Mary's camps that open source anarchy is really the way it's going to go. I used to say that back in 1990, with the collapse of the Soviet Union and a unipolar moment in the geopolitical realm, that was the moment to reorganize the UN, and we didn't. And after that failure, we have been trying and having meetings, and I've been part of, and now the forces are not there for this to really happen. But also the fact is, I believe it's a time for organizations like WHO and the bank for government-based, member-based organizations to get stronger. And it's really up to the members and up to the member states, and the member states need to, through the governance systems, to steer those organizations, but also to increase their core commitments on the funding. Because really, until I see that, everything will be tough.
I totally agree with you. So we've got just a few more minutes. I'm going to just see if we can get this one last question in, because it's a beautiful question, and I think it really is in the spirit of this whole panel. Jeff Akaba says, Ariel earlier mentioned that health systems should be people-driven, but it often seems like the approach in the engagement of those who are vulnerable and marginalized is last-minute consideration or check the box. How do we make sure key vulnerable communities are an integral part of the health system? Final reflections on that question. Ariel, since you're on, how about any final thoughts on that question?
It comes from different angles, but I always think of the triangle that moved the mountain in Thailand, right? Where it's not only the evidence and then the political community, but also the mobilizations of communities. Clearly, you cannot do that. Now, some societies, some governments are organized in democratic ways that do address that as part of the implicit systems. And I always cite here to my students, 1965 in the United States, when Medicare and Medicaid were introduced, which really in the stroke of midnight, every elderly, every disabled, and every poor person got health insurance. And those are my patients, those are the patients. So clearly there are ways from the top and from the bottom to address the needs of those who are excluded.
Yeah, I have a copy of the leaflet that was put under everybody's door in Britain when the National Health Service was launched. It's a very beautiful leaflet. This is your system. It is there for you at times of need. It's absolutely brilliant. Everybody, for everybody. Very powerful. Jan Willem and Maris, quick, brief responses.
So to make sure that nobody's left behind, you need all the perspectives around the room. As I started with my drum, kettle drum, all the instruments need to be in the orchestra, but preferably you have one orchestrator who can actually tell us we're missing some instrument, because that is the person that has that overview. Generally, that will be the government to make sure that nobody's there left behind. But in the absence of that, we have experience with the UN system, like, for example, the UNFPA, who's been sitting in that role to supporting that role of the orchestrator, highlighting which of the instruments are left behind, which are not in the orchestra yet. And that role has been very powerful. They're trusted. by everyone, respected by everyone, and their instructions are being followed. I do feel that there's a big role for the UN system to be that trusted advisor and that orchestrator in the absence of political leadership.
Thank you. Maris.
It's a question of governance. If the governance system, the governance of the system, keep the vulnerable people, vulnerable services under attention, then they will not be left behind. It is my experience, but possibly also in other countries, that the healthcare providers naturally lean towards providing certain services that they really want to do, where they want to expand. And these are not necessarily the services, the people who are vulnerable. Dependency services, harm reduction services, and so forth and so forth and so forth. So these services, these groups need to be held under attention by the governors of the system. Thanks.
Thank you. Yogesh, I would love you to have the last word, given your inspirational work in the People's Health Support Group. What are your thoughts on this?
So I think this has to be legally mandated that, local committees and and programmatically committed, mandated that there's certain proportion of people on the table. I would say 50% should be the community and not the managers and the bureaucrats and the academics. This has been, I know we have talked about it, but I think we need to put this into practice. And that's what I would say. That is the only way to get people's voice to be heard, that they should be first there on the table. Yeah.
Beautiful. Thank you very much for that very powerful closing comment. Thank you to everybody for attending. The last thing for me to do, other than to thank PMAC, is to thank this absolutely remarkable panel. This is one of the most fascinating panels that I've ever had the privilege of chairing. So thank you, Ariel Pablos Mendes. Thank you, Juan Pablo Uribe. Thank you, Maris Yessa. Thank you, Yogesh Jain. And thank you, Jan Willens Heigrund. What a remarkable 90 minutes. I've taken so many notes. I am going to be reflecting on so much of what you said, sharing your thoughts with my students in my class on policy and on health systems. So a huge thank you to everybody, much appreciated, and hope you all enjoy the rest of PMAC. Thank you so much.